what are you doing there, Luigi? Well, yeah, when he connected electrical leads to a dead frog's legs, he observed that they twitched. And so this is kind of where the beginnings of using dissimilar metals and galvanoforming began. Now, I won't judge him. We'll let history be the judge for Galvani. But what we can say is that we've arrived at a very nice place when it comes to the electroforming process. The machine that I'm using right now, and I've used a number of machines, this is the Wieland AGC Microvision Super Machine, and AGC stands for Oro Galva Crown. And so in the case of zirconia, we have to airbrush this with a conductive silver lacquer because we're forming the gold directly to the surface of the abutment. This is what it looks like when we airbrush silver lacquer. Now, in the case of titanium, we don't always have to use this lacquer. If we really want a super fit, we can actually do this directly to the titanium. But these are what they look like. This is actually using the Graham system that I'm showing here. And this is in the Microvision. But basically, if you can imagine, the gold is in a solution. It's suspended. It's a hydrocoidal suspension of gold in this liquid. And there's a current running directly to the surface of the abutment, and it's just drawing the gold out of the liquid and depositing it on the surface of the abutment directly. This is what they look like when they get pulled out of the machine. Very nice copings, and then we divest them. Now, if we did use silver conductive lacquer, we have to get rid of that, so they go into a 40% nitric acid bath. Put that into an ultrasonic that gets rid of everything. We then neutralize that, and then we can clean these copings up. And this is what they look like. Now, you might say they look kind of thin. Oh, I'm worried that I'm going to crush this coping. I can tell you, you won't. There's a hardener included in this material, and you end up with about 170 Vickers hardness. When we look in terms of fit, nothing can get in between the primary and secondary component. It's very little space there. And if we want to talk in terms of what kind of space are we talking about or dealing with, we're actually talking about a 4 to 5 micron fit. Well, let's put that into perspective. What is 4 to 5 microns? Well, if we look at the thickness of a human hair, we're looking at a 65 micron thickness. If we look at the thickness of a human red blood cell, we're still dealing with about a 2 micron thickness. So to kind of help you put it into perspective, what is a 4 micron fit? That's what we're talking about. So the machine actually will produce for us a 4 to 5 micron fit, and most of these machines have 2 settings. So the first setting will be about a 200 micron thickness of the actual coping. Now, I would use that for individual abutments, and then there's also a setting for a 300 micron thickness. I would use that more in a setting if I'm doing a long span, like if I'm doing a bar sleeve. You could use the 300 micron thickness. It's going to give you a lot of stability. And, why do we talk about fit? Well, if any of you have seen the ZipRich videos, you can pull these up on YouTube. It was basically comparing abutments and implant connections, the interface when it comes to flat connections, internal conical connections. The whole key here and the point is that we're trying to remove micro movement from the system. So that's why it's important to me. We remove micro movement. And anytime we do that, we end up with a much longer lasting prosthesis. So we talked about the primary component, the secondary component. Let's talk about the tertiary structure. This really ties everything together. Again, we go back to a digital process. So with our gold in place on the model, Muriel here is scanning. We have our pre-op. We can actually design a tertiary structure, and that's going to tie everything together. It's going to strengthen, it's going to back up the gold copings, but it's also going to strengthen the entire prosthesis. And for most of our purposes, we are using from our design, we're using a selective laser melted chromium cobalt, and that's what you see here. We can also mill this out of titanium. We're unlimited on materials. We can do a thimble cutback like you see here, and we can do pressables and cement them to this titanium framework. We can mill some hybrid ceramics. I'll show one of those cases today. To me, the beautiful thing about telescopic and conical prosthetics is that we can ridge lap or not. So we started talking in the beginning about what are some of the structural limitations when it comes to the anatomic structures of the lip, the teeth, the ridges, and how they interplay with each other. The beautiful thing for me is that with telescopes, we can make a case very much like a removable bridge, that minimal, or we can make it with flanges, we can ridge lap, we can replace tissues that were lost. So a lot of possibilities. So the first case I want to show is basically with acrylic and denture teeth. And this is Mary. And I'd be remiss without giving a shout out to Dr. Ben Ross in Charlottesville, Virginia. Actually, the both cases today that I'm showing, we did with Ben. Super guy, a good friend. I consider him to be a great friend and awesome clinician. So this is the case. This is one of the photos that Ben sent me, and I thought that this really summed up edentialism well in terms of how this affects patients when they've lost teeth. We talked in the beginning about how they don't really smile. We don't get a true smile. We don't get them to really open up. So the trick really is getting from this, to a patient that's freely smiling, big wide smile. And so we've gone through some try-in steps on this case already. We've done a lot of the preliminary work. But again, when it comes to the tools we have, when it comes to video, I just wanted to show really quickly a video that Ben sent me. And this is a super communication tool because it helps us to change things if we need to.
Okay. So let's see the smile there, Mary. Looks good. I think it looks pretty natural. What do you like about it so far?
I think it looks more like my original teeth.
I do too.
And my mouth doesn't feel as full.
That's great.
As it did with the others.
That's why we're doing this procedure, these prosthetics. Mm-hmm. So that's good. Can you shoot me a big smile there so I can see? Good. I'm going to see it from the side here. Can you count from 40 to 50 for me?
40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50.
All right. Can you say 66?
66.
And Justice?
Justice.
Talladega?
Talladega.
Tallapoosa?
Tallapoosa.
Tuscaloosa?
Tuscaloosa.
Good. All right. What makes a great smile in your opinion?
This.
This one does. That's all I need to hear. Okay, great. Thanks.
So, Ben does an awesome job communicating with the patient, and I love to see that. It's awesome for me to see here. You notice there was a little, problem with her S sounds. So we had to make some changes. Made a couple little changes with the anteriors and the maxilla. Not much of a problem, just some slight changes to improve her phonetics. And then we go through our design process. We go to our primary abutments. Here you see them. In this case, 12 implants, 6 in the maxilla, 6 in the mandible. These were external hex. We've done these on kind of every type of implant system you can dream of just about at this point. And then we have that secondary component, the gold coping, right? So we've got that 4-micron fit. And here's, once we've opaqued the framework and processed everything, here's how Mary presents at the end of this. And so, even with denture teeth, we can get some very aesthetic results. She had actually this really monster deflection. If you can notice, the midlines don't match up. Well, actually, if you can imagine when she closed, these midlines lined right up. So we always see some interesting things in patients. So she had this really big deflection. But again, at the end of the day, we ended up with something for Mary that was really natural looking, that she could smile fully with. And you'll see in a lot of our cases, we really like to rotate, particularly the mandibular anteriors. You really couldn't tell that this was a prosthesis. And this is just denture teeth. So kind of a really rewarding experience, especially when I got this message from Ben. He said here, hey, he saw the dentist who referred Mary, and he said that her husband told him that her smile reminds him of the day they were married. So again, it's, connecting with the patient to me is tremendously important when it comes to the payoff and the patient being truly satisfied and fulfilled and happy with their restoration. So that one ended up really well. So I want to move into our next patient. This is kind of using some alternate materials as opposed to using a denture tooth. So this is Alex, and this is how Alex presented. Again, another case that we did with Ben. And this was his maxillary denture that he was wearing. And there was some implant therapy. So in this case, we had 7 implants go in. And I kind of came into this process a little bit after Ben had kind of worked through some of the restorative steps. So always some good restorative steps. We've got a face bow, some tooth try-ins. This was using the Enigma tooth line. And so I kind of came into it at this point. Ben's technician had kind of done a preliminary setup. I was very happy because in this case, a bit of a class 2, and we did a little div 2. So the laterals had already been rotated a little bit for a nice natural looking smile design. And you can see here with the transparency we're designing. So always, if you've heard me speak, you've always heard me say tooth positions first, right? And that becomes a big issue. You know, a lot of what we see in dental technology right now is kind of trying to compensate or deal for things that weren't planned properly. So, man, if we can, like, let's always go with tooth positions first, get some try-ins done, get some phonetics testing done, some aesthetics, look at these things. And so here you're just seeing our scans. We're designing the primary abutments. And these are what our abutments look like. Now, again, this case was a case that we did with zirconia. So zirconia as a primary. So we're dealing with a titanium base, which gets air abraded. We do a primer, and our zirconia gets cemented to that. And once we cemented, we've gone and we've transferred this into the milling model or the telemaster unit. And now we can hand mill this with that water turbine. So we're getting this nice polished finish. Here's the abutments on the model. And here's our electroform gold coping. So we go in, again, we're electroforming the gold directly to the abutment. And there we are. Now, this is typically some of the models that we'll make. We'll make silicone duplicates at various levels. So one of the things is on the left, obviously, you see our master cast with our zirconia abutments in place. In the middle there, you see our seating jigs for that cast. And on the right, you see a duplicate at that abutment level so that we have something that we can process on. And there's kind of a whole little special technique that we use to process so that we don't damage the gold copings, but that we also have everything seated properly. And you can always ask me that outside of this event, but there's some details here that are interesting. So again, we have our gold in place on the model on the abutments. This gets scanned again because we're getting ready to design our tertiary structure. Now, in this case, we went with this material Trilor. The reason we did that is it's lightweight. We had plenty of space. We were not going to violate the minimum thicknesses prescribed for this material. So, you know, that's another thing that we always have to be very cognizant of, is that we want to stick to minimum thicknesses. You know, we start going and we start making these thimble preparations look like a toothpick, and we're asking for trouble. So always abide by the minimum thicknesses that we get from the manufacturer. So as you can see, we have plenty of thickness. Now we're still going to pick up the gold in the mouth. So we're still going to do the cementation of the gold into the tertiary in the mouth, remove that, and it gets sent back to the laboratory. Again, that's going to ensure that we have a passive, totally passive relationship. This is just a temporary. We did this directly to the abutment level. This gets sent back that same appointment for the passive pickup. So the first time the abutments get screwed in is the last time. Abutments get screwed in, the passive pickup is performed, that's removed, the temporary goes in, the patient walks out of the office with teeth. And they come back a week or week and a half later, and now the final is delivered. And they always have this temporary as a backup. So here's the day of the passive pickup, and you can see the abutments are in. This case was really interesting. As far as I remember, the patient was a heavy smoker. The mandible is another issue that we're going to have to deal with at another time. But patient lost the 2 posterior implants. You'll notice that in these photos. So far, it's been over a year and everything's fine, but this is where we're at. So at this point, passive pickup is done. The temporary is put into place. Temporary looks good. Patient's happy. And here's how the patient walks out of the office that day. And so at this point, Ben gets a little video with the patient. And, you know, we always think in terms of, well, you know, why are tooth positions so important? Well, aesthetics we talked about, right? We talked about phonetics, function. But notice what this patient brings up.
We had one fail like a year or so ago, or maybe.
Yeah, well, yeah, and then one was a wash when Dan was working on it.
Gotcha.
So I think there's been with the 2 today, total of 4.
Gotcha. So yeah, we had 2 just come out today when we were doing the pickup for the telescopic bridge.
Yes.
Right, and we went ahead and picked up the bridge, but wanted to make sure the temporary is fitting well. And so you get the temporary in now, right?
Yep.
How's that feeling?
Pretty good.
Pretty stable, right?
Yeah, I mean, it's amazing to have a pallet.
Yeah.
You know, there it is.
Yeah.
It's just a little strange, just because like we were talking in the room, the previous assembly.
Yeah.
I had so much travel. Now I'm coming up against a set of teeth.
Yeah, it's not moving.
Yeah.
Just see the teeth there. Big smile. That looks great.
Yeah.
That looks great. So even with 5 implants, that is still sturdy. We had 7 planned. We had the other telescopes in there, but even with 5, it still feels pretty sturdy.
Feels great.
Yeah.
Feels great.
So this is the prototype that we're looking at.
Okay.
What is the one thing that you can do with this that you could not do with the other denture?
Whistle.
Let's hear a whistle. There we go. Why is that important to you?
Oh, that's part of my job
Yeah. Yeah.
description.
Yeah. Yeah.
It's how I train my dogs,
Yeah.
primarily.
Yeah.
But it's also sort of a way to call the horses. And
It's what they respond to.
Yeah.
You
Yeah.
haven't been able to do that for 2 years, right?
Not for probably longer than that, since my dog was a puppy, and she's almost 7 now.
Oh, wow.
So, kind of interesting. I didn't see that coming, and I just thought, wow, how cool that, you know, in addition to the aesthetic and the phonetic and the function that we're all thinking about, well, this guy just wants to whistle. He wants to be able to call his horses. He wants to be able to get the attention of his dogs. So again, you know, when it comes to connecting with the patient and what this means to a patient, really important. So in this case, as you saw, there was thimble cutbacks. We used a hybrid ceramic. We used actually a digital tooth library, and that was based on the initial try-in. So, you know, the good people at Enigma were nice enough to lend us the STLs of this denture tooth that we had already tried in and approved. And then we were able to adapt those denture teeth digitally to the thimble preparations, mill the hybrid ceramic, characterize it a little bit, cement it to that structure. In this case, Ben also wanted some injected acrylic as a base so that he could reline it in the future. And then we added composite for the tissue. So kind of an interesting, complicated procedure here, but these cases, we've been doing more and more of them. Really interesting because they're not going to wear like denture teeth. This is going to be a very long-lasting appliance for the patient. And this is what the prosthetic looks like, very minimal in the palate. And day of insertion, this is what it looks like in the mouth. So we were really happy with the aesthetic. Really was a joy to work on this case. Very minimal and blends right in. This is day of delivery. And there's the patient. So Ben also followed up a week later with a post-insertion appointment, and I'll share that with you.
All right, Alex, it's been about a week, maybe 10 days. What's your feedback there?
It's outstanding. I mean, like I was saying earlier, the transition from pallet to the appliance is seamless.
Oh, great.
I don't know how you guys do it.
A lot of time.
Yeah, I imagine. I mean,
Working with good people, but yeah.
it's really a remarkable difference.
Great. Has your
taste-
speech changed at all? Have you accommodated to that?
I don't think I really had to. I think
Great,
I think that was okay to begin with. Basically I got my taste back. I can whistle.
Yeah? Is it better than last time? You've adjusted? Let's see. Oh, wow. Oh, yeah. That's a lot better than last time.
But I
can
think
hear
when
it.
I come in here next, I'll get your ears ringing. And that's where I was before, when I had my originals.
So in addition to that, Alex also told us that the whistling, he also plays harmonicas, and he also needs to hold a regulator because he likes to go diving. So when we think about, what are the needs of this patient, this kind of opened up a whole other avenue to me in terms of thinking about the patient, connecting with the patient, and being able to provide these things and really help to satisfy their needs. So there's how Alex finished up. I want to talk really briefly. We're just coming to the end of it now. My time's just about up. And I want to talk about further development of this concept when it comes to telescopic and conical connections. And I want to mention this little attachment that we've been using from Cendre Mateau. There's these 3 components, and they're really tiny. It's the mini presso matic, and there's the housing, and then there's a little spring. And I don't know, this slide always reminds me of something. I don't know. But basically, this little attachment is really awesome. It's really a spring-loaded little plunger, so that when you seat this in the terminal position, if you can imagine most telescopic cases, when you seat them or when the patient seats them, you know, they can feel that it's seated completely. But this, I would say, would be almost like a psychological attachment, because this actually will pop. They'll get haptic feedback, right? They'll feel this little spring-loaded attachment snap into place when the prosthesis is seated in its terminal position. So kind of a really cool situation. We've been doing a number of these now, and they're really, really interesting. We'll do these over, like in this case, a dual bar. So we can do that same concept of telescopic and conical connections with a bar sleeve system. So maybe it's a Nobel case where you have a multi-unit abutment where there's no rotational engagement and you have to do a bar. Very easy to do it because we can't do freestanding abutments in that case for telescopic. Here's another case we did, similar case. This was over Straumann implants, dual bar system, using this little mini pressomatic. And again, we still have this tertiary structure that ties everything together, adds support and strength, but really an awesome attachment. The cool thing about this attachment also is that you can back out this little spring-loaded plunger, and you could anchor this. There's an anchor that also screws into the same receptacle that you can just screw in. So let's say you wanted to maybe start a case as a hybrid. You can use the anchor, and then let's say you determine down the line sometimes that this patient really can't maintain this thing. They can't clean it properly. Well, you can very easily back that anchor out, screw in the plunger, and now you have a patient removable appliance. So kind of an interesting thing I wanted to show you guys. We're doing a lot of these, and this is kind of just a teaser. We have a lot of these cases that we're coming to completion on that we'll be showing in the near future. So again, I want to thank everyone for their time. Again, it's an honor to present, and if anybody has any questions, I can take those.
So a couple questions that came up during the presentation area, and a couple people were kind enough to provide some answers in the chat. What are you using for the transfer of the primary abutments to the hand mill and maintaining the proper path of insertion? Mark was kind enough to say the Telemaster. The software, Muriel said ExoCAD. What were the adjustments that you made to improve Mary's phonetics?
To improve Mary's phonetics, so we had to create a little more space. We had not enough space with the maxillary anteriors, so we had to move these forward a little bit. We kind of played around with that a little bit. Ben did some of that in the office, I believe, and once we found our sweet spot, we were good to go. But that can always be a potential issue with our try-ins.
Okay. What are your preferred denture teeth?
Right now, my preferred denture teeth, I'm using a ton of Refline. This is from a company, Polydent in Slovenia. Those are available through Chris at Primotech in the States. But that is my go-to tooth at the moment. Very anatomically correct posteriors, which are awesome. Really beautiful anteriors as well. To me, that's my go-to tooth.
Okay. Let's see. And why do you always choose gold copings?
Yeah, that's a great question. So you could take this to a digital manufacturer and it's nice to have a digital design, right? Because it's always preserved. However, you're going to find that when you mill a peak coping, for example, that milling process, that subtractive process is not going to be like the positive process. It's never going to be truly 100% passive. You're never going to have a uniform 4-micron fit. So I do it for the passivity. It's just a better result. And we've gone down the road of trying to mill these copings out of peak, for example, never the same result.
Okay. And let's see, a couple people I think asked about the hybrid tooth material, and Muriel might have mentioned it somewhere in the chat, but if you could just mention that again.
Yeah, so hybrid ceramics are starting to catch. We've used some products from GC. So there's the Sarah Smart material is one of the products from GC. That's a hybrid ceramic. Also, Vita has Anamic, also a hybrid ceramic. They have their differences, but essentially they are both hybrid ceramics. And so there is a filler. There's a matrix that binds the ceramic together. Super in terms of coming even closer to the, how would I say, the performance of a natural tooth. So you're going to find that these hybrid ceramics aren't quite as brittle as a ceramic, as a pressable. So we've been having great success with them. We've got a number of cases in the mouth, going over a year or two now, and we've just seen great success. I'm very pleased with them.
Okay, let's see. What's the minimum prosthetic space requirements for the telescopic conus prosthetic?
So excellent, good question. So typically, to give you an idea, if we're dealing with a 0-degree abutment, we need about 3 millimeters of height to get retention. But to be honest, everybody wants a number. They want to say, is it 15 millimeters like a screw retain case? Well, honestly, it just depends on the situation, because if you can imagine, number of implants, they're all custom abutments, so we can always tweak these. So I would say in like some worst case scenarios, I've been able to get away with much less than, than a 3 millimeter abutment. It kind of really honestly just depends on the situation.
Okay. In the last patient, why the support pedestal under the gingiva?
Yes. So in the last patient, why the support gingiva, or the support pedestal under the gingiva? I need a little more specificity on that. A little more specific.
Aaron, I think you need the little acrylic saddles you have underneath that bar. What lays?
Oh, yes. Awesome. Thank you. Good question. So on the tertiary, when I get ready to do the passive pickup, I like to have a tripod or 3 tissue stops. Yeah. So we actually just make those in a composite, and that's so that when we have predictability, right? So I put those on the model, on the master model, so that the cement spacer is accurate. So when they take that to the mouth, they want to make sure that when they cement the tertiary to the gold, that they're seating that tertiary down to those tissue stops. That's essentially what they are, is tissue stops.
Okay. Do you mill the hybrid ceramic out as full teeth or crowns?
Yeah, so we mill them out as crowns, basically. So we adapt them to the individual thimble preparations, and they get milled out as crowns, but it's just that material, and then it gets cemented to the tertiary structure.
Excellent. Okay. Any of you gentlemen, Peter, Alex, Nandis, any questions from you?
I thought it was fabulous, Arian. I mean, that's why we brought you here. I knew it would be, and we're really happy. I thought the chatter going on during your presentation has been fabulous. So that alone shows that everybody is really engaged and interested.
Awesome.
And the concepts and the techniques, I don't think there's anybody doing them better. So thank you so much. I can't thank you enough for being here with us.
My pleasure, Peter.
So for those of you seeking CE, Nandis.
Yeah. First of all, thank you for this presentation. Really, really great presentation. Very documented and very nice cases and final results and photos. Just one question. I saw some telescopes that it was especially to the interproximal surfaces at the cervical area, subgingival. So how you manage when the secondary telescope of Galvano goes subgingival? Okay, it's removable, but every time goes subgingival and then up, subgingival, up. This is my first question. If there is any problem, if it is like I saw maybe 1 millimeter subgingival, if there is a problem of this, and the second one, how you manage the after 1 or 2 years some anaerobic microbiotics that absorb from the interface between cement, galvano, all this stuff together.
Okay, excellent question. So to address the first question, we try to always keep them actually at the margin, right? So I don't want them to go subgingival. In some of these cases, maybe in the impression we didn't get quite what we needed, so they may appear to be a little subgingival. We're also looking at how much tissue we're displacing, but we're always actually trying to keep that right at the margin as opposed to subgingival. So I hope
margin, or sometimes supragingiva, in order to avoid the bra effect that you will get a little bit higher after 6 months, 1 month, because of the bra effect,
Yep.
So periodontal pressure, and to get a little bit high of hyperplastic soft tissue.
Yeah.
Maybe it's depending the final height, right?
Yeah,
It's
absolutely.
the available height. If you have a lot of height, you can go super gingiva. If you have just a tiny, you can get a little bit, as much as possible.
Yeah, and so the thing is, there's a balance, right? Because if we go too super gingival, then we have like this undercut where we can have things collect. So we always try to really manage the tissue and hopefully we can stay right at that margin is really ideally, or just barely above. Yeah. When it comes to the other question, what was the other question? The second one
about the anaerobics and smell, microbiotics, all this.
Right. So in terms of that, really what I try to always do is the gold coping, the tertiary structure is actually just shy of the finish line of the gold coping. So we always go for a transition. If you looked at the intaglio of this prosthetic, you shouldn't see any of the chromium cobalt. That should all be covered. So it should be a beautiful, smooth, surface from gold to acrylic or to composite or to whatever we're using.
As much as closer as possible. Yeah.
Yep.
Okay, to avoid infiltration or whatever.
Exactly. Yeah, we don't want anything getting in between. Yeah.
Thank you. Very great presentation. Thank you so much.
No problem.
One question, Arian. You mentioned you do the crowns now in hybrid ceramics, basically, Star Smart or dynamic. Are you now going more towards a polishing of the teeth or glazing?
So far we've really only done glazing. So we'll characterize a little bit, we'll prepare it, we'll glaze it, and that works really well. I mean, so far we've got some good, I don't want to say long-term yet because we're maybe 2 years out on the oldest case, but so far we've had great success.
Yeah, I mean, that's what I see too. That's great. And then when you do hybrid ceramic crowns, are you finishing the pink in acrylic or composite?
Typically, if we're doing hybrid ceramic, then we're going to finish with composite for tissue.
Composite. Okay, perfect. Cool. Awesome presentation.
Okay, so if we missed anybody's questions or if you thought of anything at the end here, make sure to just write them down, make a note, and we'll have a little bit of a longer session at the end for a Q&A for all four of our presenters. But for now, for those of you laboratory members seeking CE, the validation code for the second session is IDT 0417-2. Again, IDT 0417-2. And we'll now take a short coffee break and resume at 2:55 with Nandis.
You did a great job, Harry, did a fabulous job, and really one step after the other. I think it's great. Yeah, so it seems like, I mean, I know we had close to 8 sign up, so it's possible that you'll get some at some point, and some at other points, and Okay, I think we're back. Everybody with us? Nandis, you there? I see you.
Yes.
All right, great. Well,
I finished my coffee.
you finished your coffee? You drank yourself, you drank your picture. So, quick announcement, I'm not sure. Whoever is writing on their screen, please stop that because everybody is seeing that. So I'd appreciate it if whoever has a touchpad and you're doodling, don't do it.
The last one, it was an elephant, I think. It was nice.
Yeah, unless you're really an artist. Otherwise, don't do it, please. So, Mr. Nandis.
Yeah.
My great brother. So, a few things before you get rolling. Thank you. I just want everybody to know, you know, I said before, and I meant it, when I called Alex first, and I asked him because I knew how much he would want to be a part and how helpful he and Danielle would be, and I was right. After that, I started thinking about who else really we should have here. And of course, Nandis comes to my mind almost everything I do in this profession for the last 10 years. We've been friends for over 10 years now, and it's been a great friendship, someone that I really care about a lot, and he's a great guy across the board. I'll tell everybody that when I reached out to him and I said, you know, I'd like you to do, and before I finished my sentence, he said, yes. And I said, okay, but I want you to do a video thing. He goes, I'll swim there if you want, was his request, was what he said to me. And I just want you to know how much that just, you know, how much it means to me, but also I think he knows I would do the same for him in 2 seconds. So, one great thing about this profession that I think we all miss out on a lot is the friendships and all the great people that we have that are so willing to share and so willing to help. And I got to spend in May last year with Nandis and his family and friends, and it was an honor for me. So I'm really proud to have you here with us, Nandis. I thank you for putting this, for organizing your work and slides, and for the beautiful artwork on the coffee. Oh, I did that, never mind. So with that said, I'm going to hand it over to you and say it's all you. Please have fun and show us all that beautiful stuff that you do. So thank you, Mr. Nandis, and have some fun.
So, Peter, thank you so much for these nice words. It's my honor to be with you guys, and thank you for this invitation, Peter, and the idea, this great idea. Thank you so much. And of course, I know you did it already. You swim also. I think I can say you swim to Greece and give us a nice lecture. Not really swim in Mykonos, but it's okay. So, and you did a nice lecture for us, for Greek technicians. Thank you so much for everything, for your help and your knowledge. Let's start. So, one moment to close this. Okay. So, the title is a systematic approach to the aesthetic needs of our patients with ceramics. So when we have to work today with cases, sometimes we are thinking we need to go digital, we need to go analog, we need to combine. As a person, I'm not so digital person. I like more manual work, but of course, in order to work with the modern materials, we need to combine digital technology and also to use our analog skills and knowledge as well in order to apply and to have a nice final restoration. So what we need to do for every case, even if we work digital or manual, we need to customize according individual characteristics of the patient. I think the previous lecturers, they analyzed a lot about this. They gave us a lot of examples. So, for example, to manage and to work with this case, the initial situation, of course, you need to customize. You need to customize about and to apply individual aesthetic, to customize and to find solutions and to about function, occlusal, periodontal issues, and even when you have to combine with different techniques and different materials between teeth, implants, bridges, crowns, so needs a lot to customize a lot, and especially if you have to do with patients and that need high with high aesthetic demands, like this patient. So lately, I had a case, and I want to present first of all this case to you. It was a man. The name is Panos. He's an ophthalmologist doctor, 53 years old. He has a lot of worn dentition and with 7 millimeter reduced vertical dimension of occlusal. Bone defect on number 9 due to occlusal trauma and a lot of occlusal disorder, loss of the anterior guidance, and extensive cervical erosions. Also, he was a very funny guy, so I had the opportunity to make some nice photos, funny photos for this presentation. Initial situation, analysis of the portrait of the patient, relaxing lips, smile, low smile. As you can see, you cannot see the mandibular teeth. There's not any appearance of mandibular teeth. And also you can see the lips, the corner of the lips, down, the aesthetic. Here, it's low aesthetic. A lot of erosions, occlusal erosions. And the vertical dimension with calm muscle tone. You can see the previous, the relaxing situation, and the occlusal situation, back and forward, relaxing with a calm muscle tone and occlusal position. Okay. Intermaxillary space on centric relation and vertical dimension in rest position. It was around 10 millimeters, a lot, really a lot. So we get some intraoral photos. We can see here a lot of facial erosions, cervical erosions, a lot of chippings also, incisal chippings because of the bad occlusion and the different position Now the protrusion of the lower jaw, lateral views. We don't have any angulation of cusps. It's completely flat, the occlusal surfaces. So we had not only to apply good aesthetic here, but to restore the function, occlusal and function. Number 9, it was compromised with moderate to poor prognosis, but after the occlusal equilibration and the surgical periodontal therapy with bone graft, the mobility was less. You see here, we had this problem. Okay, so it was normally, and we had to extract this tooth, but he didn't want it. He was afraid. He didn't want with any way to extract this tooth. Of course, in the future, it would be a problem. And he told us, no, if I have a problem in the future, I will extract, we will put an implant or a bridge, but now I don't want, I'm afraid. And also, he didn't want to grind a lot his teeth. He was afraid. He was asking for as much as possible minimal preparations. Closer, 6 units, 6 anteriors. You can see the problem here that we had the clinical cervical line in a different level than the right central. So it was some minimal crown lengthening in these cases in order to have more symmetry margin line here. Occlusal views, no angulations of cusps. We can see clearly the dentine, dentino-enamel junction, enamels.
Hey, Nandis?
Yes?
Would you mind? I'm just curious if I'm looking at the photographs. I didn't hear you mention, or I missed it maybe, besides for the functional attributes and the wear that's happening, the secondary component of chemical. Right? I'm seeing a secondary chemical component. Was that something that was diagnosed, or?
Always I respect, you know, the patients, you know, like informations. That's why sometimes I don't refer and I'm not telling if it was acid or something, you know. But when I ask him, he tell us no. He didn't have like, you know, like reflex of like to, you know, with food or something, anorexia or something. And we can see that, but because the most of the erosions are not lingually or palatally, it's facially.
Right.
So
the parafunctional erosion, something.
Yes, maybe acid, saliva, but lingually was not so much, almost nothing. Most it was occlusal and facially, a lot of acid. So maybe it was food or something, but I don't think that it was like you know, it was like the reflex of. Okay. So,
thank you.
But always I'm trying not to say a lot because I just respect the patient's, you know, private information. So that's why. So as you can see here, palatally, maybe here is the answer. We don't have a lot of erosions. We can see the morphology, the previous morphology, maybe on lateral a little bit. It was a lot of enamel. We were lucky here. So we decide, especially for the 6 anteriors, to make veneers. So yeah, it was a classic case about veneers, lower as well. There is no, as you can see, Peter, there is no lingual erosions, occlusal, and look the canine, facial, dentine. We have almost dentine here. There is no enamel. But lingual, we have a lot of enamel. So we were lucky because we know that, okay, we have enough quantity of enamel, so we get a good cementation, at least at the margins. occlusal mandibular photos. As you can see, lingual, there are not a lot of erosions, but mostly it is occlusal and facial. Chippings, also fractures about the occlusal or bruxism. And I think that when the time was, after a lot of time, and when he was losing more quantity of VDO, he was doing more chippings because of the wrong position of the lower jaw. Maxillary, there are some small erosions here, but not so much if we compare with the buccal surfaces. So for the maxillary and lower anterior, we decide to make veneers. And for the, I'm going back, and for the posteriors, we decide to make tabletops onlaced 3/4 to with facial coverage. So what we did, first of all, we made the first scan without any preparations, any grinding, nothing. The scanning of the unprepared teeth after the small management of the soft tissue to the central area. Intraoral scanner. It was a big problem with the central. Almost I wanted to close my camera and to stop to make documentation for this case, because it was the black area for this case. Anyone can wondering why we keep it with this absorption of the bone, but it was a matter of patient. He didn't want to extract. Upper and lower and occlusal, and then we get bite registration. So after that, we print two initial models. This is the situation. We put it in our articulator. And at the same time, we mill provisionals. Provisionals like cells, in order milling provisionals, in order up to the unprepared, ungrinding teeth, in order to verify aesthetic and the new vertical dimension of occlusal. In these provisionals, we don't care about the margins, if it is subgingival or supragingival or whatever. It is like a mock-up or aesthetic evaluation, Peter, okay, and the patient's mouth in order to get these informations and to verify the new occlusal. So we are not so interesting. We need to have a good marginal fit, but not so much to care about the emergence profile or to change margin lines and whatever. Lateral views.
Andis, we have a question. Is the provisional milled?
Yes, provisional mill. Mill provisional, yeah. And this is the portrait with the provisionals of the patient. The comments, it was, Nondas, I would like my teeth a little bit more bright. So I didn't agree with him. I told him that you had very dark orange, yellow orange teeth. So it changes them a lot. All your friends or family, they will see the big difference, and everyone you will see in your mouth. And also, you are like 52, 53, and of course you will have this case in your mouth a lot of years. So don't. It's not good to you have the appearance like okay, look at me, I have the white teeth. So I told him, please keep it like this, at least like this. And also one of his comments, it was to make more round edges. And also for this, I didn't agree, because I explained him that his previous teeth, it was a lot of had a lot of edges and erosion, so it had a lot of concavities of the incisal edges and a lot of very sharp edges. So now it would be good if we made it more round and more female teeth. So hopefully he agreed with me, and we proceed to the case.
Another quick question: how much did you raise the bite?
It was about 7 millimeters. And good question. And we share. I will tell it now that we share this distance, this millimeters, 50% to the maxillary and mandibular. So 3.5 for the maxillary and 3.5 for the mandibular. Then we proceed with preparations and final scan. Mandibular preparations for veneers for the 6 lower anteriors and 340 to the 3/4 to the posteriors. So for the posteriors, we cover only the occlusal surface, like an onlay, and the facial surface. The occlusal surface, it was untouched. We didn't grind nothing on the occlusal surfaces, almost untouched. Also, it was a chamfer to the lingual occlusal corner in order to get more cementation surface with the enamel. So to get better cementation and better cementation with enamel.
A couple people asking if the bite was reestablished in centric relation position.
Bite, it was before, we verified the bite before with anterior guidance, and then we had posterior bites, so we used them one by one during the scanning. So we use the left one we scan the right side, and then we'll use the right side and we'll scan the left side. But the first verification, it was with the incisal G, the incisal guidance. So we get the first STL files for the case, lateral views, and palatal lingual views. Here you can see the type of preparations, chamfer, a little bit deep chamfer to the lingual palatal surface in order to get more enamel surface for better cementation. Almost we didn't touch the contact surfaces, the contact points. And also it was like 360 veneers for this lateral because it was a lot of erosion to the palatal surface. And also here it was 19, so we extend a little bit to enamel in order to get better cementation. I think that the success in this case, it was not my work or maybe the dentist's work, it was the quality of cementation, especially for a case like this. So then we proceed to design the case in the laboratory. First of all, we mark the margins. About the restorations, we decide to make nanolithium disilicate case, and then second margins in order to make the model, the alveolar model. We proceed. We make this with the same design, the restorations, and the alveolar model. Insertion paths. Mandibular. So models are ready, and then we close some undercuts, some risky areas, difficult areas before design. Some holes, undercuts here, so I will not be. It will not be necessary then to grind and to fit a lot, to spend a lot of time to fit the crowns. Full contour setup. According the full contour setup, according the provisionals, and then we start to remove material in order to make veneering. In this case, we remove manually. Adaptations of the crowns to the margins. And then we get at the same time the alveolar model, the alveolar dies, and the restoration. Lateral views, it will be veneering until the second molar. Occlusal view. And then we use this system. It's the only system that exists in the market to do what? To make all the work, all the design of the pressable crowns digitally. So we get the STL files, first of all, for the models, and we print the models in this printer. And then we get the STL files of the restorations, and we put them with this specific software direct on the pressable ring. Is the ring, is the virtual reality, a replica of the ring that we use for pressable of the KEMA, and we put the STL files, the crowns, direct in the software. So we don't mill them, and we don't print them before. You can see we adapt it according to the ring. And then we print. And we print direct up to the ring, to the base of the ring. And this is the space for the plugs. So we have ready the base of the ring, space for the plug, and our restorations. The printing models, the printing dies. The fit, it was really, really good, very, very precise. And we use these materials for pressable, nothing nano lithium disilicate. After press, we have the cases on the articulator. Foundation firing. First wash bake, and then it's the time for a human factor to apply ceramic and to apply aesthetic. And this is the final case. So what we did here, we moved all the manual work of the in order to get the wax pattern, to mill the wax pattern and put them in the ring, and then to invest and press them. So all this procedure becomes digitally. So we can do pressable cases with the biggest of the part with a digital workflow. The final portrait of the patient.
Hi guys, a warm smile from Greece, and don't forget, apart from basketball, we know how to make teeth. Enjoy.
His final portrait. And let's proceed to the next case. Single central restoration, implant restoration, dentist, made already and very good emergence profile according to the symmetrical central. So we need to design now the framework for this restoration. We decided to make this restoration with zirconia material. And as you can see, the design, it's not a simple case. We don't design like a copying or to use the libraries of the software to push just the button and it's okay. It's or a simple cutback. We need to design like architectures. We need to try to find weak areas like this area, the palatal surface, this patient, in order to make monolithic. And also how we will apply and how we will design the emergence profile. This is very, very important. And this is the design after milling, before sintering. As you can see, all the subgingival parts of this single central are all of them with monolithic zirconia. Contours, the design, it's a combination between concavities and convexities in order to apply good aesthetic and good support of the ceramic. Of course, for cases like this, it's better to do a try-in on the framework in the patient's mouth in order to check the emergence profile and in order to see how much subgingival we are in this area. Concavities for more aesthetics, but at the same time, good support mesial and distal. And of course, this is the weak area, in this case, the hole. So we need to apply at least this part of the crown with monolithic design, maybe all the palatal surface, but at least this part. Otherwise, we will get a fracture for the uncompressed forces during due to protrusion. And then we start layering. It was a difficult, really difficult case And of course, it was not a case for a one-bake technique. It was a lot of characteristics, different values, different translucency, and a lot of internal characteristics. So it was classic case for internal stain. So first of all, we proceed to make internal stain for the framework, and at the same time with a foundation, the wash bake. And then we had to manage the cervical translucent. So first of all, we start with cervical translucent material. I'm trying to explain with general terminology because, of course, different people works with different ceramic systems. So I don't want to use the names of my ceramic that I use. This is blue lines are nice, but are not mine. We support, first of all, we start to support with opacious body. Why? In order to support the opacity. This is very important in order to get the internal reflection of the light. The internal reflection of the light will give us the right amount of value at the end. And it will permit us to apply the number of the translucent and transparent that we need in order to achieve this complicated aesthetic. We proceed with dentine. Dentine, then secondary cervical translucent, more light and more translucent. And then we do a cutback, and we start to apply some internal modifiers like T-blue, illusion of depth materials, bluish in the proximal, opalescence at the incisal area, and like mamelons areas. And for this case, it is a mamelon area. It's not like really 3 mamelons because it's a old patient. And then some gray distal translucent. And then we cover everything with pure transparent in order to create something like a dentino-enamel connection. Then we proceed with a little bit more bright enamel, especially to the line angles, in order to get more external reflection of the light. And we finish the whole surface with lusters. Lusters are more fine-grained ceramic that give us more opalescence and better surface. Then we proceed with some internal cracks, and then some smaller internal cracks. And as I told you, this is not a case for one bake. This is a case for internal staining technique. So we stop, we bake it. We did then internal stain. We check them, we reduce, we correct them, and then we proceed to apply lusters and to finish the final macro and micro morphology. This is the final macro morphology. We check with this gold powder. And what is important for this case, and this, as you can see, is a perio patient. So this is important, the incisal guidance, how we will manage the incisal guidance in order to avoid a lot of forces for this implant and maybe some fractures. And we get the final result. What is very important here is the emergence profile. Of course, we were not able to close the diastema, of course. And the next case, it is a young man, about 25 years old. He's a quite famous singer here in Greece. This is the previous situation. The dentist, Alexandra, remove the old metal ceramic crown, and it was a lot of discoloration for the previous preparation. So Sandra proceeded to make internal bleaching. She did really nice work here, and she made provisional, acrylic provisional in her dental office in-house. So let's go front, and we start to design a simple single central, okay? But if we go back, let's see what happened here. Look, the occlusal, the lateral, really it's out because of the lower canine. There is a lot of the overjet here, and seems like a simple single central, but really it's not. So we start to design in the software the central, and it's easy to make a copy, right? Everyone can make a copy. We can push the button to make a copy or to make it back, but for this case, it will be really risky if we make just a copy, and then we will have a lot of space to apply ceramic. What we need to do, we need to support some critical areas, like here, mesial, incisal mesial, and distal incisal, in order to support the ceramic, to support also line angles, transition areas here, and also to copy characteristics of the palatal surface. And just take a look on this. As I told you, he's 25 years old. What do you think? I think this abrasion in his central, it's for a person like 65 years old. So we have a lot of abrasion here. So you can imagine if we just design a copy, or we use just the modules and the libraries, whatever, of the softwares, we will not able to avoid maybe a future chipping. So we need to design according to the function, to use our articulator, and also to support and to take care about this area. Also the palatal line angles. So even a simple crown has to be a system, has to be an architectural design, not just a copy. Everyone can design a copy. You are not, it's not necessary to be dental technician to design a copy. So this is after milling here. As you can see, there is a combination. There are a combination between convexities and concavities in order to support the ceramic, and at the same time to apply better optical properties and to increase aesthetic. And after layering of ceramic with just one firing, just one bake, we do the first drying. First of all, we need to check the value to see if we are successful about the value. This is my mainly concern when I have to make a single central, to be successful about value. Then opacity and color, it's easy. So this is the first drying, just one bake, mechanical polish, and we are ready to make some modifications, change here some yellowish areas. So after modifications, we get this result. The most important value. So we didn't get a gray appearance. This is right after cementation. Of course, we need to wait about the recovery of the soft tissue. And of course, we take care about the macromorphology and the micromorphology, surface texture. This is very important. Then we made a small partial veneer here with Alexandra in order to close this incisal triangle. Final portrait of the patient. And as I told you, he's a singer. So we need aesthetic, we need good function, we need our single central to be strong according his occlusal, but also we need to keep the same phonetic for this patient. Thank you very much. So,
all right, Nadas, we have a lot of questions for you, so we'll start with your first case. So what kind of temporary material do you use?
This was a PMMA from a disc, CAD-CAM disc. There are a lot of brands. I don't want to make any advertisement now. So there are a lot of brands. What is important for me to be a nice multi-layered blank in order to get not like a massive color, but a nice A2 with enamel and translucency. Okay, I used a nice, stable, multi-layered material.
Excellent. Okay. Was the patient reprogrammed and the provisionals? Can you give some details on that?
Yes, of course. Of course. Occlusal function. The dentist worked a lot about the occlusal. Not so much because Not so much because it was the occlusal record before. It was really we worked a lot before. We get a nice occlusal record. Lateral and incisal zig. So it was just to use because we also put him on a centric relation. So it was about him to start and to spend a little bit time to use the new situation. But it was very comfortable for him because when I asked him at the beginning, really, sometimes if you eat something, when you eat something very strong, right? And sometimes you feel a little bit tired and you try to eat it and you don't feel comfortable. And he said, yes. And then even with a provisional, he was more comfortable. And he started after 1 week, 10 days to speak better as well.
Excellent. And I asked you during the lecture about how much you raised the bite. You said 7 millimeters. How exactly did you decide on that number, on that amount?
Measurements, like the previous lecturers, they know that, like dentures. Exactly like dentures. We measure the relaxing position. We measure the occlusal position, and then from the relaxing, we just remove 3 millimeters, exactly like a denture, like the dentures.
Excellent. Okay.
And with the incisal zig, we just took care to put in the centric relation the mandibular jaw. Okay. But the measurements, it was exactly like dentures, as we do in dentures.
Got it. Excellent. Do you use physical articulators, fully adjustable or semi-adjustable in these cases?
It was semi-adjustable.
Okay. And how much time did you spend designing the maxillary?
To design the maxillary, the restoration, you mean?
Yes.
How much time? Really, as I told you, I'm not the designer. I just correct. I'm mostly manual. I like to work with my brush and apply ceramic. And so it was like a normal case that anyone design. We just moved from libraries, the morphologies, then we adapted to the margins. It was not like really something special. We had a pre-op about the provisionals, second scan file, so it was like normal case. I don't know how much time it was from my persons to design, but not something special or something like very difficult.
Gotcha. Okay. So for the single implant case, what was the implant on that case?
In the first one, the implant case, yes. What was?
What was the implant that you used?
What implant? What brand of implant?
I believe that's the question that's being asked.
I think it's not matter of brand.
Okay.
Okay, can be one implant. It's not good now to refer about brands. I think it was 3i, but it was the good work that it was good work from a clinician. He prepared very nice the emergence profile. So and also he used his natural tooth about provisional. So he adapted the natural tooth, the extracted tooth, with acrylic, and he made exactly the same emergence profile as before. So we didn't get a lot of changes.
Okay. Let's see. Why did you not use pink tissue for the model?
In which case?
In the second case, I believe.
The second case, the case of implant, I use it.
You did? Okay. Okay.
Yeah. Maybe it was not in the, but always I use 2 or 3 models.
Okay. And a couple questions about the internal crack
also
you created.
Soft tissue, but also solid model, and we sculpt. We form the plaster according the new emergence profile, and also not also the emergence profile, but the asymmetric shape of the cross section, of the horizontal section of the cervical area. The same, in order like to copy the symmetrical central.
Okay. And a couple questions about the internal crack that you created on that central implant. First of all, just how did you do that crack line? Did you apply any stain?
Stains, and sometimes I mix with opaque. Depends the crack. The most important is to be successful to create some shadows and not just a color stain, because for every crack there is no only color. There is different absorption of the light and different reflection. From one side it's more reflection, and from the other side it's more absorption, and there looks like a shadow if you see a crack. Even if you break a glass, the left and right side, it's not the same. Okay, it's like a shadow and reflection, more reflection area. According what? According to the inclination of the crack. Because the cracks are not all of them parallel and straight and symmetric. Goes from the mesial, like almost with different directions according the lens surface of the central. Let's say that the surface, it's a lens, so we have different orientations.
Okay. I have a couple people asking about the printer that you used, and I don't want to, again, you don't want to ask you to name a brand.
Because it was a system that we tested, and it was from this system, and it's the only one. So there are no competitors. So it's a system from the Tekema, and the printer, it was from the Tekema. So I work the first case in order to test the system. So I had a good fit, so that's why we proceed and we finish the case. Marginal fit, okay. The most important. Because as I told you, I'm more manual, so I love pure pressable. I have very good marginal fit. I'm more happy with pure pressable than milling in blocks.
Okay. Even with proper supported zirconia framework, do we still need to be concerned with porcelain chipping?
No. not today.
Easy answer.
Materials are exceptional. If there is my opinion is that if we have a chipping, even after that, if a good design, good connectors, a good material, it's a human mistake, dental technician or clinician mistake. You never in our life we had chippings on metal ceramic. A lot.
Excellent. Okay, so we'll move on for now, and if again, if we missed anybody's questions, we'll have a little bit of extra time at the end for questions to any of the four presenters. So for laboratory folks seeking CE, the validation code for the third session is IDT 0417-3. Again, IDT 0417-3. So our final speaker for the day will be Mr. Peter Pizzi. Everybody knows Peter is a prolific international lecturer, laboratory owner, editor-in-chief of Inside Dental Technology. It's my pleasure to get to work with Peter on a daily basis on the journal, and we're honored to work with him on this. As you know, he was the driving force behind this event. Just the passion that he has for the profession and for educating and just wanting to give back to this profession during a difficult time, and really at all times, but especially this week, he really wanted to get this event put together and make it great. So thank you, Peter. So without further ado, Peter.
Thank you, Jason, so much. And thank you, Alex, Nandis, Arian. I can't thank you guys enough for putting together everything in this short period of time. And I think I put myself in maybe the bad spot, because I think my goal now is to sum up everything that we did today and kind of go through it and kind of put it all into a package of how that works for us. So I think two of the keys that I kept hearing today from each lecture was how we communicated the process and the materials that we use. And those to me were the kind of two keys that I kept really thinking through. And for us, let's be realistic. Our job is to emulate what nature has done. So understanding not only the materials and the communication, but then how it fits intraorally through the emergence profiles and managing the pink and white versions of what we do. And I think that's where all the challenge starts to come in for us. So realistically, when we look at our cases and we're looking at them in a macro stage, or a micro stage, I should say, meaning that, okay, patient wants to do the number 9 or the 2-1, well, that seems fairly easy to us in the beginning. But how that communication process works through becomes more challenging. The quality of the photographs and the information that's shared with us from the doctors and also from the patients, because let's be clear, some of them don't really like having their photos taken or are long distance, and we're communicating through video and other means. But I think where this sums all together for me is it's really easy for us to look at the picture at the top left-hand corner of the screen and say, okay, I want to use zirconia, I want to use metal, I want to do this, I want to do that. But that's not really our job. Our job is really more about, look at the human on the right of your screen. Look at that patient and look at his face and look at how he feels, because the eyes are telling you right away, it's more than just the ugliness of that central that's bothering him. He's not comfortable with his teeth. He's not comfortable in how he feels. And part of us has to be a detective, right? Part of us has to be able to really look at the patient and start figuring out all the goods and bads. Now, some of you might have caught some things already. I know I showed this case last week in a web series, but you'll notice that the number 10 or 11 is not the lateral. It's a cuspid that was moved into position. So right away that changes our game, right? Because now you have a thicker root, you have different tissue emergence, and you don't really have the shape or form that's going to work well. Fixing that central isn't going to be just enough. So for me, a few years ago, when I first started working with IDT, I wrote an article called Patient Care Philosophy First. And for the clinical people out there, that might sound a little silly, right? Of course we manage and take care of patients, but do we really manage them as well as we should? And how much are we looking at the entire stomatic gnathic system of the patient and not just the single central that needs to be done or the full mouth that needs to be done? So for me, the topic or the gist of the article was, our future is going to demand on a dental team who communicate at a much higher level. That's the doctor, the technician, and all the rest of the people around that, right? So whether it's perio, pros, orthodontics, our job is to be able to look through the whole process. And I do that by breaking it down into the face, the dental facial, which is the close-up with the white end paint, and then the dental. Rather than just starting with the dental and coming back to the face later on. I want to start from the face. And I think as you start to look at the face, you start to see, again, all the uncomfortablenesses that that are present for this patient. Another challenge for me, and something that I've worked through a lot in the laboratory, is we as laboratory technicians a lot of times receive models and scripts that tell us what to do. I never really felt comfortable with that. I think we're supposed to be a teammate to our doctors, and our doctors are supposed to be a teammate to us. So one of the things I've incorporated in the lab a few years back was we don't work on cases without photographic or video information anymore. And the reason for that is we're just not good enough. That's really the truth. I'm not sure how anybody can say, well, I did a great job on this tooth. I never saw the patient or I never saw it in the mouth, but I know I did a great job. And that to me, as you've probably heard me say over the years of lecturing, that's the badge of courage all us technicians wear, right? I've been doing this forever, so I must be really good at it. Well, maybe we're not so great at it. Maybe we really need to be able to step back and look. So for me in my laboratory, I want to pick up a case and I want to see the human. I want to see the individual. I want to understand where their incisal plane is, how they feel, and what all their lip dynamic is. And I have to be able to address and see all the needs that are needed. What I don't care about is how strong the material is. And I know that goes against the grain of our industry, but it's a really silly statement. I don't care how fast it can be milled or produced, because that's not how we manage the human body. And I don't care about the pricing, although I understand that there are needs to be addressing to be able to treat everybody. I don't have an issue with that. But I do think that we kind of go in the wrong direction. What I want for our technicians and our groups and our dentists is to be viable. What I really want for our profession is that people seek us out because they think we're the best or we have the most knowledge. And if we don't really do that, then we don't understand how to manage our patients. Obviously, the goal is not to prep teeth, and that is really the number one goal. Now, in Arian's case, he doesn't have that luxury all the time, right? Most of the time he's dealing with, as Alex said, the black hole, and doesn't have the ability to say, well, I want to save tooth structure. No, he probably wants to save bone whenever he can. But in the end, our goal is the same, to manage the health of the patient, minimally invasive. Now, in this particular case, it's a little difficult because why? The tooth has been prepped already. And in order to restore aesthetically, we're going to have to prepare other teeth. But we have to start to say, what material do I want to put there? How hard should it be? Which one should I use? Do I want zirconia, lithium disilicate? Do I want metal ceramics? Because they all have viability to them. And what I'm not thinking of is how hard the material is. I want to be clear with everybody that we teach you, or our companies teach us all, that megapascal strength is where things belong. And I would argue that that's not true. Matter of fact, I always say megapascal strength, MPa, was really a term that was used to measure building materials like concretes and metals 100 years ago. And they measured them to figure out when they break. And that's not really the way the mouth works, because the mouth works, and I think Alex might have said it, or Arian said it in their lectures, that the mouth works because strength is a combination of rigidity and flexibility. So having the ability for our materials to have some movement in them is very critical. Making them harder and harder doesn't mean they're really better for our patient. Let's be realistic. Everything can break. There's nothing that can't break. Our job is to manage it and make sure that we understand what is best for the oral environment. So I've actually taken this list from a presenter I saw a while back, but this kind of breaks down what megapascal really looks like in humans and in materials that we use. You guys all already know that probably the average zirconia starts around 1200 megapascal, and then the more translucent or the more we go into cubic, kind of the less hardness they get. But let's look at nature. Nature is approximately 130 megapascal. And the reason it works most of the time is because of the combination of rigidity and flexibility. It's not about one, it's about all of them. And our job is to manage all of that. So in the end, what I'm managing through my cases, although I'm really thinking about aesthetics and opacity, and I like the way Nanda says it a lot because I use that line so much myself. What am I really trying to create? The proper value based on the internal opacity of the tooth or translucency of the tooth. Never am I thinking about how hard can this be. I'm thinking about how do I fill this space? How do I fill all this space that you see here on that number 9, which, by the way, and I'm sure all my friends would agree with me today, that's the hardest one to do because I have the most amount of space to work with and I have to manage the opacity and the light transmission. Whereas when I have less space to deal with, I have a different issue, but a little bit easier to manipulate the light and the color. So it kind of depends on how we do it. Now, I stole this picture from my friend Nandis, and Nandis always talks about that one bake concept, and he's the best at it in the world as far as I'm concerned. And I got to use this a while ago, but I think it's funny because as a Greek, Nandis does that one bake technique, and I wanted to show you that I'm Italian, and I do a one bake and regattas and different things, and it goes into the oven, one bake, and it's done, and it's perfect. Nandis is a little bit more of a challenging one bake scenario. In the end, what we're really looking for is to make everything harmonize with the patient. And I know when I show this case, I've showed it a billion times, everybody seems to focus on the teeth, the incisor ledge, the translucency, the embrasure space. And yeah, those are important things, but what am I looking at? The human, the patient. Look at his eyes. Look at how he feels after we did what we did for him. And that's what really matters to me, is how we really address the patient's need across the board and make them feel more comfortable about what they do. So in the end, as we're talking about options and aesthetic materials, I'm going to kind of very, very quickly run through some of these. For one, if we're talking about removable or fixed detachable, there's a lot of great things about that. They're cost effective. You can rebuild many structures. You can use them with implants or without implants. You could use them as combination cases, so half acrylic and half other materials. Today, we can mill them and print them. But I have to be honest, and Arian might come over and kick me when I say it, although he's only got one arm right now, so he can't hurt me too much. But I see everything in acrylic world as long-term provisional. And I don't mean that as an insult to the acrylic world. I mean it because, one, the materials have a lifespan, 3 to 5 to 6 years, getting better, but also the biology is changing. The bone changes, the tissue changes. And as those things changes, we will need to readapt the restorative process. Now, that doesn't mean that all crown and bridge is perfectly for a lifetime either. It wears and chips and breaks. But I just think we need to take a different approach in how we talk about the materials we use. And I think we confirm the process is better to our patient as long-term provisionalization, in the sense that we will have to make adjustments or changes down the road as things go on. The other materials that we use is lithium disilicate. I think aesthetically it's a great material if we layer it, but I want to be clear. There's lithium silicate and lithium disilicate. And there are two different materials, and they actually have different optics to them. And our job is to understand which optics are correct for us and which ones we use for different situations. Again, I think they're always better if we're putting some layers and ceramic on them. That's more important for me. And I think they could be, I know they can be adhesive or cohesive, which I like, meaning that you saw in Nandis' case, he wanted to make sure he had enough enamel to bond to. So that would be a cohesive practice, but doesn't mean we couldn't cement them if we didn't have the enamel to bond to. They do tend to go to the grayer side, especially the D-silicates. I think the silicates have a little bit better optical view. So, but again, that's about managing your choice of ingot and your choice of material that you're using. And in the end, they have a wide variety. We could use them for abutments, inlay, onlay, veneer, full coverage. I don't like them for bridge work. I don't recommend that. Zirconia oxide, same thing. I think it's better if we're layering it. I think we get better aesthetics from it. I don't care about the high MPa. I think that's actually kind of silly that we push that so much. Ideally, it does have a good span for bridges, but the limitation is connector sizes, right? The bigger the connector size, the less embrasure space and emergence profile that we can create. So that's a challenge for me. And even though the science might argue a little bit, I don't think it's truly bondable yet. There are tests and there are studies that show that we're bonding it, but it's not a truly bondable material at this point. So for me, where I've gone to, and I think Arian brought up a few of them, is the hybrid materials. I really love the hybrid materials. Why? Nanohybrids, ceramic-based fillers, what these are more similar to nature. And this really allows us to put things in the mouth that wear similar to the way nature does. They're also millable and they're chair-side use, so they have a lot of advantages to them. And they're all cohesive, meaning they bond very well to each other. And I don't want to throw out metal ceramics because metal ceramics are still there. They're still very useful materials. And for me, I do a lot of big implant cases, and I think there's a lot of uses for metal ceramics. The challenge with metal ceramics, I think, is the understanding of the layering process and how we create the layers and how we really can create depth and color with inside and not make them gray out or look a little bit dead with the light spectrum. But they're still option for me, and it's something that I use quite often. I think when we look at the single central concept, and Nandis showed two beautiful single centrals, we have to start thinking right away what material works best for this. And I'm sure, like all of you, I've made cases out of a metal ceramic and said, no, that wasn't the right material. I'm going to switch that to zirconia. Or maybe I used zirconia and I realized I wanted metal. And I have to start to think through the process of figuring out how do I mask or utilize the prep shade behind me, and then how much space do I have to create depth and layering and color. So I'm going to have to make that determination a lot of times right from the beginning. And I do that by choosing materials that are going to give me optics that I need and setting those materials up to refract and reflect light. And I think this is a really important point that Nandis kind of made a little bit in his program. It's really about controlling the light intake. I'm not going to go deep into that. I think Nandis covered it really well. I do have a web series that's running every Tuesday, and I will break materials down individually if you guys want to jump into that at some other point. But for today, the goal is to emulate what we see in nature through the surface topography, the texture, the light distribution, and the warmth. And I think that takes a lot. It's not an easy process. I wish I could say I get them perfect all the time, but I know I don't. And a lot of times it's just being able to look back and kind of really dive into your work. I think one of the best testers for us as ceramists these days is the use of polarize, where I can actually shoot my restorations and kind of evaluate what I'm seeing optically if I'm getting similar light distribution across the restoration as I am with natural teeth. And when we go into non-substructures, like Anandis had talked about a little bit too, feldspathic veneers and other materials, I'm great with understanding, or I enjoy the fact that I want to use feldspathic anytime I can. And I'm sure some of you look at a case like this and think, well, wait a second, we need some strength there. We don't need any more strength than the teeth had, 120 megapascal. We just need this patient not to fall off their bicycle and smash their teeth on the floor anymore. That's really what broke the teeth. It's not a functional issue. So we can go back to an old school refractory. I can use my opacious materials and my more opacified or fluorescent type materials, layer my dentins and enamel, and create these little tiny window veneers rather than re-prepping out the whole tooth and lowering the biomechanical nature of the structure that we already worked on. So these little chips will go back to the doctor, and he or she can place them. This is actually Dr. Ricciardi here on Staten Island with me, and those are placed, and now we can move on with our patient right back to where she was without having to prep teeth and make 360 margins and changing everything. So I think material-wise, we really have to be able to look and say, where are we going? Do we need really hard? Do we need really soft? Do we need somewhere in the middle? And every case is different. So as I look through my cases and I look at the teeth and where they belong, I have to start being able to look at the whole and say, okay, what else is happening? Are there functional concerns? Is there plane issues that I'm trying to manage? Where am I going to understand? And that always starts for all of us the same way. It really starts with the diagnostic phase. For me, the diagnostic phase is always step one, and that is, where do the teeth belong in the face? And by the way, it's no different for Arian, right? He's working on an edentulous patient. Nandis or Alex or myself might be working on either or. It could be a denture or it could be crown and bridge, but it's the same thing. Where do the teeth belong in that human's face? And to be honest with you, why I've adopted the term aesthetic evaluation is for that reason. Because we don't know exactly where it is until we see it in the face. we could all have our opinions, and probably all of us speakers today could argue over it should be a 0.5 millimeter longer, it should be a 0.5 millimeter shorter. But until you put that in the face and evaluate it, that's when you know. So our wax ups are nothing more, or your wax try-ins are nothing more than an aesthetic evaluation. One thing I'll throw out, not to change the subject too much, Arian, I see you're there. One of the things I've been working on in the lab, because we do a lot of denture things too these days. I'm sorry to make it sound like denture things, so simple. I don't mean it that way. The point I'm making is the concept of the bite rim, to me, I feel like is archaic. When people ask me for a bite rim, I'm like, why? So one of the things we've worked on, and I'd share this with you, and you're probably levels ahead of it with me anyway, but one of the things we've worked on, especially with the ability to print and mill today, is being able to print a tooth-formed bite rim, right? Basically that has teeth, and be able to give that to the doctor to place in the mouth. So now we actually see white teeth and shapes, and the doctor then has the ability to shorten them, cut the midline a little bit different, or add a little wax to them. So what I'd love to see in our profession across the board, and maybe you could help me with this project, because I've been working on it for a while, is I don't want to ever see a pink wax bite rim again for the rest of my life. I want to see a tooth trial bite rim that we can actually look at teeth in the human's face, rather than wasting this one step on a bite rim that's pink. I don't know if you had a thought on that, if you want to just jump in there and throw it in, but I wanted to address that when you were going before.
Well, you know, it's interesting because we have done a number of cases where just based on facial, just based on cranial anatomy, we can do a setup very easily. And I can tell you, if it's based on anatomy, 9 times out of 10, you're actually going to have something very aesthetic, midline. I mean, you're going to be okay. We just did one of these recently in Maine, and it's almost shocking sometimes about, how much you can really trust those landmarks.
Right. So what Arian's addressing from, I'm sure everybody's on the same page, but incisive papilla 9 millimeters to the facial, or you can measure the long branch rugae, or fovea palatini to the incisive papilla times, what is it? I think 9 divided by 4. Like there's all these formulas, right, of where teeth belong in the arch. And I think that's important for us to know and to be able to utilize. So thank you. After we start to get our evaluation, that image or that usefulness now goes back to the doctor. And they need to use that for prep design. Of course, we want to have minimally invasive preps. I get it. At the same time, what are you restoring? If you're restoring a case like Nanda's showed, that full mouth case with the chemical wear, well, you know right away you're prepping almost full coverage, because you need to cover the chemical component of that restorative process. At the same time, we have to decide, are we making a color change? Is it a functional change? How many things are we looking at, and what types of preparations are needed for that? And this is where our partners really come in handy. And obviously, when we can save the tooth structure, of course, that's what we want to do. So anytime we can go veneer or Von Lay, and we don't have to go full coverage, that should be our first choice. But remember, when you make that choice, you also dictate the material options, right? Because if you give us a 360-degree prep, we can pick any material we want. Once you go into the veneer or Von Lay concept of an occlusal and a facial, we've now limited the material options. It's not going to be zirconia. It's not going to be metal ceramics. It's going to be in the lithium silicate and disilicate families. And there's nothing wrong with that, but I just want to be clear. And then obviously the doctor's impression is king. And I think as technicians, we don't talk about this enough. I'm lucky. I work with 10 pretty fabulous doctors locally and worldwide. And when I see impressions like this, I get excited to go into the lab and start seeing that cast and being able to be repeatable. So this process is just as important for the doctors that are watching us today. It's easy to I think a lot of the doctors see a case that Nanda's did and they go, oh, that work is beautiful. I'm going to send him my case to make it look great for me. Doesn't really work that way, does it? Right? I think Nanda's would tell you, if you don't provide the right amount of space, the right amount of contour, the right margin integrity, it doesn't really work just for somebody else to make it look prettier because they happen to be so artistic and so great. So we need that quality of impression. we go to our provisionalization and into our shade determination, and then we start in what we do and what we love to do. And like Nanda said, there's nothing I love more than going into my office on Sunday morning and picking up my brush. I enjoy it. It's still something I'm passionate about today. I'm sure Arian feels the same way when he's looking at his teeth and his contours, and all of us have that same concept. I know Alex feels the same way. And what am I trying to do is to think of how I distribute the light and the opacity of what I do to make teeth look real, to create the right embrasure spaces, to create depth and warmth and value and translucencies and all the little surface topography that comes into play as we work through our teeth. And as we work through the process, I have to be honest with you, it gets a little frustrating, because as much as we spend all this lab time trying to make everything look beautiful, I have to tell everybody, we don't know if it looks beautiful until we see it intraoral. And all the time and energy we spend, it's not until we put it in the mouth and we get to see the gingival harmony and the papilla fill in and how the coloration falls against the gingival tissue and how the lips wrap over it, that it really means something to us. So in the beginning, all that effort is really going to be rewarded at the end if we do it correctly. But let's be clear, even around the lips isn't enough until we see the face. And this is why looking at the face, the white, and the pink is such an important process to us. And remember that I want to make it that the patient feels happy. I want to make sure that they feel comfortable with what they are and who they are. And sometimes they push our boundaries. They want things more white than they should be. They want things more round than they should be, as Nanda said before. But part of our job is to give them our opinions. And in the end, we can't force them to do what they want to do, what we want them to do. But maybe we're not always the right patient, the right technician for them. Sometimes we have to stand our ground a little bit and know what's right and wrong, because I don't want to make every case OM1 straight and no embrasure space. I'm not proud of that, to be honest with you. I want to be able to make them look real in the patient's mouth. And I hope you guys are all looking at this case and saying, well, Peter, you're talking about materials. Which material did you use for this case? Well, you guys might be a little surprised if I tell you that I used them all. I used metal ceramics. I used zirconia and layered on them. I used zirconias and micro-layered, just a little tiny bit. There was 1 or 2 monolithic crowns, and there were 6 or 7 feldspathic veneers on this case. Now, why would I use all those different materials? Because that was right for the patient. That was right for the long span bridge, where I didn't have connector spaces for zirconia, or I didn't want the rigidity of limiting the periodontal ligament when I put a very rigid bridge in the patient's mouth. I use feldspathic veneers. It's my favorite restoration to go to whenever we could be minimally invasive and just want to change shape or color. And I'll use monolithic materials when I need to, more based on space, not necessarily based on the hardness. I don't really care about the hardness in the end. I really care more about the functional contributions that's going to make. So I want to draw from a little bit of what Alex said. And Alex started talking about the face and the dominant and non-dominant sides. And I wanted to be clear that years ago, we really broke faces down into 3 types, right? We kind of talked about square, round, and I think ovoid were the 3 basics. Well, today, we're a global world, right? I mean, so many races have mixed in different scenarios, and our facial features have changed so much. And I think we have to really look at people as individuals. There is no square face or round face. There's many different types of faces these days. And by the way, just as important in the crown and bridge world as it is in the denture world. And what do I mean by that is, well, when I look at a face, we've been taught, I'm going to say incorrectly taught, that symmetry is what we're looking for. Symmetry is not what we're looking for. And if you're one of the people that are out there today who thinks injecting tons of Botox and making everything perfectly the shapely same is good to you, it's not what's natural to me. Doesn't mean you're right or I'm right. It just means that our goal is to make ourselves feel as comfortable as we want. But from my perspective, nature is what is beautiful. When I see a face of a woman or a man that's 50 years old or 60 years old, that character is beautiful. That's not, I don't need them to make themselves perfectly symmetrical. To me, it starts to look weird. So you see here, when we start to look at the face and we take this concept of symmetrics, and I take a very beautiful face here and I put it into a bar. Well, notice right away, you should be able to tell that the two sides of the face aren't the same, the definition of zones are not the same, and the interpupillary line is not the same. So these are all different. And if they're different, I'll prove it to you, as Alex did to you earlier. One, if I take her face and break it up, and you start to see that face in two different sides, you should be able to tell right away that these are not the same. And when I put these back together, you'll notice again that I've made two different people, right? But they're the same person. So this is where I struggle, and maybe for Arian, I'm gonna make the assumption that when you take a denture mold, a denture teeth mold, and you're about to put it in the face, why your cases look so beautiful to me is because you're not just putting the mold in the face. You're tweaking the mold to fit the face. You're tweaking the contact, you're rolling a corner, you're customizing it. And that's why when I see your cases, they don't look like denture cases. They look like beautiful restorative work. But let's be honest, people, how many of you see a denture case and look at it and go, oh yeah, those are denture teeth, right? Why? Because they're symmetrical in a non-symmetrical face. And digital hasn't helped us there, right? Because we're taking a beautiful mold. One of the questions I saw come up on Nandis's chat sheet 5 times was, what mold did you use? What mold did you use? What difference does it make which mold he uses? It's how he interpreted how to fit those into the patient's face at the end. And that's where we really need to understand that this becomes much more important to us to manage the face and not just pick a mold out and pop it into the face across the board. So I try to watch that all the time. And like I said to you right from the beginning, everything starts for me, where is the incisal edge in the face? Once I understand the incisal edge position, it really allows me to determine the horizontal plane across the board. And then once I understand the horizontal plane, that makes me understand how long do I want the teeth to be. So how much pink am I going to expose as compared to how much white am I going to expose? And that's based on a few things: age of the patient and the lip dynamic and the aesthetic that we're looking for. So again, just like Arian, which was why it was so important for me to have Arian here with us, I'm looking at it as a dental problem. I'm not looking at it as a denture, a ceramic, a partial design. I'm looking at it as the stomatic system and how we can develop that. And I don't even think about the functional attributes until I've understood where the horizontal plane is in that face. And then I'll come back and start to work through the envelope of function and where those teeth belong. No different than if I'm setting up a denture. So when I take a patient like this, and this patient is such a lovely woman, she's gone through so much before she got here. I think if you look at her face, you can tell right away that she's a sweetheart, but you can also tell she's uncomfortable. I can't get her to smile. I can't get that lip dynamic to see the biggest smile that she normally walks around with. And of course, if I divide up her face, you can start to see right away that she's extreme in the two different parts of her face, right? It's really an extreme amount how big and different they are. So what I would ask people when I'm teaching is, where do her teeth belong? Let's pretend I'm putting a denture in her mouth. Do I want to make these teeth 1 millimeter longer, 2 millimeters, 5 millimeters? What is my aesthetic evaluation going to be? And I'm going to have to do that by utilizing the information. Now, let's be clear. The information is big. I need the photographic information. I need the transfer of information. And I'm not a big Facebook guy, and we could discuss that as much as you want at later dates, but there's lots of flaws that get incorporated into a true face bow, which, by the way, we don't have true face bows today. We have ear bows. Big difference behind how we use those and how we old school used to use a dot that referenced our circular point, but I won't go there now. So I'm a fan of a Cois analyzer or a facial analyzer, and that gives us two things. It gives us the functional parameter of where the teeth belong on the articulator or where the arch belongs on the articulator. It also gives us the aesthetic parameter of where the teeth belong. And this is important because I want both of those. Just to be clear, and I'm not going to go too far into the functional components today, but just to be clear, when you use a face bow or an ear bow, you're changing the angulation of the occlusal plane. And you're changing it because you're using a third reference point, either Camphor's or Frankfurt. And that's really not proper. What we really want is how the patient really exists. And for that, the facial analyzer gives us that. So look at the two obvious mountings. One is a face bow, one is a facial analyzer. A big difference. Now, why this becomes important for us is because, and by the way, I'll throw a shout out to not a company in general, but the fact that you could do this on every instrument today, right? Years ago, you had to do this on a Panadent articulator. Today, a friend of mine actually developed that you could do this everywhere. And that's really fabulous for us, that we can work on any instrument today and still get this. And what is this? This is horizontal reference. I now have the ability on any instrument that I'm working on to understand the horizontal plane of the patient. And if you remember when I started, I said, I want that patient's photograph on my pan. Why do I want it? Because when I'm mounting that case or pouring those models, I know right away if the patient's plane looks like it's going up to the left and the face bow or the facial analyzer looks perfectly straight, I know it's no good right away. I don't want to wait till the end to figure that out. Also, the beauty of using the plane allows us to say, you know, I think I'd like to extend the incisal edge on the 8 and 9 2 millimeters. Well, I could just take my table and drop it down 2 millimeters and now wax to that. So I never use horizontal, I never lose horizontal reference. And I also make sure I want to use that even in the digital world. As I use digital equipment, I want to have that same horizontal reference. So in the end, I'm not a big digital guy for that. I really like to do this for real. And I developed a system a few years back. I know McLaren teaches it now and a lot of other people are teaching it now. But in the end, what I really try to do is come up with a transfer system that works much more accurately. And the way that works is we're using a PVS material that's clear, so a very clear compression material. And I'm using a hard acrylic tray. And I'm using both of those together. Why? Because I get the hardness and rigidity so that the PMMA or the bisacryls don't expand too much. And I have the ability to pop that in the mouth and use a little bit of the palatal seat to get an accurate transfer. And the other beauty of this is if you choose to use composite, you can light cure through the clear tray, or you can remove the hard outer shell and then wiggle the soft shell off. So it gives you a much more accurate transfer. And when we applied our bisacryl transfer to Ella, I think you could see right away what we did for this patient. We follow the same protocol like Alex talked about before. You don't want to hand the patient the mirror. You want to take their picture, you want to film them, you want to show them what it looks like, especially when it's additive. Because the additive ones are the hardest one for them to really understand when they're staring at it from an inch away and seeing the bulkiness of the materials that are on there. So in the end, this wound up being a full mouth 28 unit restoration zirconia layered ceramic case. This case is probably, God, 6 years old already at this point. It was done here on Staten Island with Dr. Bernadette Sava, who did a fabulous job managing it all. And in the end, I think you'll notice that here's what it matters. Look where the patient starts. Look where the patient finishes. And listen, I could tell you how sweet she was and how wonderful she was, but sometimes it's better to hear it from the patient themselves.
Everything was fine. In fact, I recommended Dr. Sawa to 2 people. I told them, and you'll have your teeth done by the same man who did the girl on Modern Family. But I don't know if they're going to take me up on it.
Oh, that's nice of you. What do you think now in the end when you get to look at what you see?
Oh,
Oh, are we still on? We okay?
Yeah,
Lost my-
Looks like we lost your screen share, Peter.
Not sure why, but hold on. I'll reshare. We'll get back to normal. Okay, we're all good?
Yes.
Great. So let me get back to where we were. Sorry.
everything was fine. In fact, I recommended Dr. Sawa to 2 people. I told them, and you'll have your teeth done by the same man who did the girl on Modern Family. But I don't know if they're going to take me up on it.
Oh, that's nice of you. What do you think now in the end when you get to look at what you see?
Oh, I love it. I love it. In fact, I forget how bad they were. Every once in a while, like my daughter-in-law's shower. So they took a lot of spontaneous pictures, you know, like.
Yeah.
And if you remember, my teeth were so small that when I smiled, I looked like a shopping bag lady. You couldn't see any teeth. And in these pictures, I look good in all of that. Very nice.
Yeah.
And then I was saying, what happened? I guess the weight helped too. I said, oh, I have teeth. That makes a difference.
Well, if you remember when you came the first time, I said to you, the goal is when you're done for everybody to look at you and say, what have you done? You look
Yeah,
great.
right.
And not to say, who made those teeth, right?
Yeah.
So that
No,
was
and
kind of
that's
the goal.
exactly what's happening. Even my husband's aunt, she said, you know.
So you get the idea, and I think the concept is that is really what we want, isn't it? You want people, and don't get me wrong, I get patients who say, no, I want everybody to know I paid to have my teeth done. Okay, that's a different approach to how we're restoring, isn't it? But in the end, you really want your patients to feel comfortable. And when you look at all your patients, I did this case probably 10, 12 years ago now with Dr. Mike here on Staten Island, and it's funny because when I Googled this patient, she's a famous actress, and when I Googled her, these are the photographs that I saw. And this is a famous actress. She's in 9,000 great movies, and she makes a lot of money, and she's a sweetheart of a lady. But can you imagine that as beautiful and as famous and wealthy as she was, or she is, she walked around feeling that uncomfortable to smile. And her teeth really weren't that bad. It was really just how she felt about them, the perception. And in the end, we didn't have to change lots of things. We just had to change enough to make her feel comfortable. And some of that was through a digital design. Now, I get a kick out of this digital design concept because this is 10, 12 years old, this case, and we were taking digital forms and putting them on the picture to kind of evaluate what we wanted to do years ago to figure out what was right and wrong for the patient. And the reason that we wanted to do that is I always use the famous phrase, the famous phrase, are we giving the patient back the teeth they used to have, or are we giving them teeth that they have never had? And I think that's the difference probably between Arian and myself sometimes. A lot of times Arian's giving them the teeth they've never had, right? Because they're all missing, he doesn't know where they were. We, a lot of times, are just replacing what they used to have and improving it a little bit. And it makes it a lot easier on our end, honestly, if we're just kind of adding to where they are and what they're doing. But the reason I actually even put this case in was because I remember when we did it, and we did the diagnostic wax up, and then I took the diagnostic wax up shell that I had used and I flipped it over. And you should notice that when I flip it over, it's not the same. Why is it not the same? Because the face isn't the same. One side is dominant, one side is non-dominant. Buccal corridors are different. So this concept, and for the doctors who are listening, that every tooth should be the same shape and the same size and the same color, is just plainly incorrect. That is not the way teeth are, and that is not the way nature has established them. So we'll finish up her veneers. We never got to her lowers, unfortunately. But in the end, I think it's about 10 years later now, and when I see her on a magazine or a cover, I'm like, wow, how great does that feel? That look at her feel comfortable and smiling and laughing and all the things that she's doing now, based on the fact that she just feels more comfortable with where she is and what she's doing. So I'm going to walk you through one last case, and I'm going to kind of close my presentation and try to save us some time so the four of us can answer some more questions for you guys. I'm going to go through this case a little quick because it's just a summary of all the things that we talked about, and I'm not going to go into all the details that I'd like to go into, but I'll just give you the story of Esty. Esty's a fabulous lady who was born with some cleft palate issues and some form issues. And she spent her whole life feeling pretty uncomfortable about that. And I can tell you that when she was, I believe, around 15, 16 years old, she had her first orthognathic surgery. And she had 2 or 3 since then, by the way. And without going into too much detail, I'm going to tell you that after her second orthognathic, I believe, or maybe even her third, I'm not sure, the bone between the anterior 6 front teeth and the actual skull never joined. So she actually has a few millimeter gap that runs through that bone, which means
it was open bite.
Open anterior bite. So that's a whole nother issue of where the teeth are. But remember, the bone not healing was part of the driving force of what we're thinking of, not to be too evasive on the patient. Now, at some point, somebody had placed 2 implants there. And I can tell you when I saw the implants right away, my first thought was, we don't need them. We don't want them. They're not helping us based on the tooth position and the V-shaped angle of her arch that we're dealing with. And remember, you can't see it well here in this x-ray. I actually have another x-ray I couldn't find last night, but it shows a little bit of spacing that exists between the bone and the actual skull itself. So in the end, you can see that she's a true class 2 and she's really out there, and the jaw is set back very similar to mine. So functionally, she's not as much of a concern about the restorative options, but I think aesthetically is where the problem comes in. And sure enough, in 2005, she went to one of my doctors that I was working with. And the minute that we started working through the cases and we cut off her old existing crowns, the tissue shot up like out of nowhere, and all the worst things that could have happened started happening. And things seemed to start just going wrong from a real scary point of view for all of us. So she wound up going through a few more surgeries, and we did some bone grafting and some tissue augmentations. And in the end, we had forgotten all about where the teeth belong in her face at this point and started thinking about how do we now manage what she has left without making it worse. But long story short, I kind of went through the process just like Arian or Nandis or Alex would have done. Where do the teeth belong in her face once we started getting control? So I used a few denture teeth. We started to do our setup. And then because I'm a ceramist or a waxer, I like to bring that back to wax. So we'll duplicate that denture setup, and we'll start adding wax to tweak the shapes and make the changes and create dominant and non-dominant sides in the wax up. I don't like to take too much credit for the wax ups today. Jen in the lab does 99% of them, if not all of them these days, and does a fabulous job with them. We'll take that wax up and we'll start to work through our provisional material, just a straight PMMA, and then we'll put a little pink acrylic on it or a pink composite on it at this point. Now, I want to be clear with you, a little trick that I kind of like to share with people. Whenever I'm making provisionals and we're using pink composite, I purposely do not want the pink composite to match very well. I don't. Why? Optically, composites have a much better light interaction than ceramics, so that's a challenge. And two, I want to make sure the ceramic is an improvement of where we were. The last thing I want to do is have this beautiful pink composite, and then we go to put pink ceramic on it, and the patient doesn't like it as much. So I'm okay making them a little darker, a little lighter. I don't care which way you go, but don't make them perfect. The reference at this moment is really just to do what? Know where the white and the pink start and stop. And I can tell you at this point, Esty would have been fine if we didn't touch her ever again. She was happy with the provisional. She loved it. She felt good. Look at the difference in her smiling. Even though the pink is 5 shades different than what we want it to be, she didn't care. She loved it. So in the end, now we're going to start going back to the restorative options. And I'm going to tell you this case for me is an all-on teeth case. I know in the implant world, we talk about all on 4, and we think we can have 4 implants and put 9,000 teeth on it, or 5 implants. Well, in this case, we're going to do all on teeth. And the all on teeth are going to be only 5 abutments. That's all she really had left to manage our way through. And I'm going to use my horizontal reference for everything I do. I know where her teeth belong in her face. I know where the horizontal plane is. And now I can just go through my build-ups. And I'll start with my opacious dentins, and I'll start working my way into my dentin materials and creating the shape and form and the look of the overall shape. And then I'll finish that up with enamels and everything else that I need to make it look somewhat real. This case was a little tricky. Whenever I work with metal ceramics, I use 360-degree ceramic margins. In this case, because of the lateral position, I have to actually use pink ceramic to work the ceramic margin material, which is a little different because of the firing parameters. And by the way, I have to be honest today, not only do I use ceramic margins for all my metal ceramic cases, I've gone back to ceramic margins in most of my zirconia cases. And the reason I do that is I feel like I get a better optic with the fluorescent materials, and I create a little bit more depth that way. I'll break that down in one of my webinars in the next week or two if you guys want to get into one of those webinar series. But in the end, here's our final restoration, and we're going to put this in Esty's mouth. And you can see we're managing the look to see what the rest position looks like, the display that's being displayed, and when she starts to smile and open her mouth. And I don't love, it's not my favorite case. If I can go back and make some tweaks, I would love to, but she was going to have none of it. We tried the bridge in, and she wanted it in, and she was done. And we kind of went straight forward at that point. So I think I could have did a better job making some tweaks. I asked her to give me her meanest, angriest face that she can give me, but she couldn't hold it for very long, because in the end, she was pretty happy and excited. And this was an all-on tooth case. And you can see we wound up adjusting those implants down and actually jumping over them because they weren't really in a useful position for us at the end. Okay, so this is the final case I'd like to show. I'd like to kind of open this up for questions. I think we're in a pretty good time frame where all our speakers really kept to their their times and really did an amazing job. So hopefully you have some questions for me. And if not, you're still welcome to ask questions for Alex or Nandix or Arian, whichever one you want at this point. So thank you guys so much. And I'll wrap up a little bit at the end after the questions.
So Peter, a couple questions that came in through the chat. First of all, can you detail your thoughts on the differences between lithium silicate and lithium disilicate?
Yeah, so that's a great question. So I'm going to actually break that down on Tuesday in a web series. If you guys want to email me, I'll go through it a little bit more detail. But for today, the real difference is the molecular structure. So lithium disilicate tends to be more of a log-like shape. And that log-like shape, when you press it and it flows, sometimes makes it a little bit more difficult to get the uniformity out of it. And obviously, both of them have zero fluorescence, and we have to create it. And I find that the lithium disilicate tends to be a little lower in value in general, where the lithium silicates, because of the process of milling them on a block, tend to be a little less overfired, and we have the ability to get a little bit more aesthetic out of them.
Okay. On the case where you mentioned you used all the different materials, why not use a pink stone cast?
Pink stone. Why didn't I use I'm assuming they're asking why didn't I use a gingerol mask or a gingerol pink mask? And if that's what they're asking, we only really use pink gingerol materials for the cast with implant cases in general. I work every case from a solid stone alveolar model. So every case that I work on, I have a solid cast. If it's a veneer case, it's an alveolar cast that the dies are removable. But if it's a solid case where I'm doing bridge work or single units, a die model is only used to create the substructure and for the design. But after that, everything is worked from the original, from a solid cast. And that's because, like I said to you right from the beginning, I'm not good enough without the information. And the information that's on that solid cast is the emergence profile and the papilla heights.
Okay. In the context of the availability of multi-layer zirconia and the array of translucencies, do you think it's possible to achieve such excellence with minor cutbacks and layering?
100%, right? So I might have argued that point 2 years ago. Today, we're gearing, I think Nand has kind of showed a lot of that in his presentation, where we're utilizing our zirconia or lithium disilicate to be more supportive, not only functionally, but optically. I want to reflect more light or absorb more light. And because of that, I could put less layers of ceramic on it based on the final shade that I'm looking for.
Okay. And let's see. Is milled lithium disilicate better than pressed from an aesthetic standpoint?
So let me define those two. Lithium disilicate is a pressed material. Lithium silicate is a milled material.
Okay. All right. Let's see. One more. What margin material did you use with the PFM?
So for me, PFM, I'm always using just whatever margin material, the ceramic I'm working with. So whatever ceramic you use, all of them have margin materials. All the margin materials are higher firing and highly fluorescent. So if you're I used Vita, but if you use Creation or Noritake or GC, whichever one you use, they all have a higher forming margin material. And by the way, I like the margin material as my first bake or my first liner. So as an example, and I'll show this in the webinar in 2 weeks, I believe, I'll cut back my ceramic margin on zirconia. I'll use margin material to fill it, and then I'll use the same or different margin materials to create shape and form and contour to manipulate the light. I feel like the margin materials have a much chunkier look to them, and they help a little bit more with the optics.
Okay. And somebody says gold-based alloy?
Always gold-based alloys for us, yes.
Okay. All right. I think that that's the questions for you, Peter, unless any of the other speakers have questions for you.
No questions from the speakers. No. They're not allowed that.
And I have a couple more for the rest of you, so I'll jump onto them right now, and people can still continue to ask questions to Peter. One for Alex. Could you elaborate on methods of assuring proper superimposition of various wax-ups on pre-ops on pictures?
Wow, that's a complex question. Holy moly. I was hoping I can take a vacation now. Can you repeat the question, please?
Could you elaborate on methods of assuring proper superimposition of various wax ups on pre-ops in pictures?
In pictures.
I'm not sure. I don't mean to cut into your question, Alex. It seems to me like they're asking, and I could be wrong, it seems to me like they're asking, how do we verify that what we've done in the wax up is in the patient's mouth that are the same thing? And I think that's why I addressed that with the tray. But I think that's what they're asking. I could be wrong.
Okay.
I hope so. Or in the pictures, on the photographs, basically. So, well, I mean, let's say this: verification digitally. Let's elaborate different things. Verification digitally can be done in a proper software, like what I showed, basically with landmarks on face or landmarks on teeth. You can transfer landmarks, basically. That's one way you can do it. Another way doing it is what I showed, basically, physically, to actually design a diagnostics or a digital wax up and then actually transfer to the patient's mouth with different tools like a stent, like a matrix or similar, to kind of verify if that is the same look. You can then actually take a photograph of that transferred diagnostics in the patient's mouth and then retransfer back the photograph into the CAD/CAM software to kind of verify again the same, if you have the same look, if you can keep basically the same consistency in the design. If that is the question or the answer, I'm happy to have it answered here. Otherwise, please just maybe rephrase the question differently in the chat. That would be great.
Okay. I'm not sure if the person who asked that earlier is still with us, but we'll keep an eye out for that. Let's see. So we still have a few more minutes left. Arian, using the CONUS system with all the mastication forces, chewing, grinding, knowing that there's a great fit, roughly how long is the cross-arch stab? How long? What's that?
Probably stability.
That's what I'm thinking, yeah. How long before it starts to loosen up?
So great question. But let me also make some definitions too. When we talk about CONUS, you know, there's a manufacturer that has a CONUS system on the market that is a very specific abutment, right? So it's a 5-degree abutment, and there's a cap that's pre-manufactured. That's a little different from what we're doing. So I've had some issues with that system in terms of it locking in place and just different issues. But when we're talking in terms of what we're doing, which is a truly custom abutment, you could say that typically any metal-to-metal connection, like a titanium to a gold coping sleeve, like what we showed, you're looking, I would say, on a minimum of between 6 to 8 years of very good retention. The earliest it's going to wear out is between 6 and 8 years. You'll start to have a loss of retention. When we're talking about zirconia as a primary, we get a little more lifetime. We're typically looking at a minimum of 10, 11 years of retention, which is awesome. But also keep in mind too that we have a lot of clients that initially say, well, look, we'd like to make an extra set of copings, and we have the patient hold on to that. So essentially, when that lifetime of retention wears out, whether it's 8 years, 12, 13 years, at that point, they can very easily remove that coping from the prosthesis, place the new copings in place, and do an intraoral pickup, and you're back to day one of retention.
Excellent. Okay. One for Nandis. If we're baking a big bridge, like 10 units of zirconia or PFM, what temperature should be used?
Okay, yes. Let's reply for this. A good question. And I saw another one quick question for one bake technique. How much it takes to make one bake technique? Let's yes. Combine these two questions. So I will reply with question. So how big is your case? It's one tooth. Okay, the first guy asked about a big full arch. Yes, it's full arch. It's 6-unit beads, 3-unit beads, or 1 crown. So we need to modify. it's gold metal, it's chrome cobalt, it's zirconia. Zirconia is a bad transmitter of temperature. So we will follow very slow rate and slow cooling program. So if I bake a full arch of zirconia, implant full arch, that means a big volume with pink ceramic, very big structure, and I bake it like the company recommendation program, as there are in the users, prospect, you will get it out of the furnace in 3 pieces. And if maybe after 10 minutes, you will hear a crack and the second one crack, and then we will get 2 or 3 pieces. So depending the material, depending the volume of the object, we need to think clever and to modify our procedure. So we need to know the nature of the materials and work different with gold, high precision gold, that it's a good transmitter of temperature, and totally different with zirconia, that is a very bad transmitter of temperature. So we need to go very, very, very slow and very, very slow cooling until the, let's say, not the room temperature. Room temperature is the best. Otherwise, we will include stresses. We will bend the arches. Even here in Greece, in the past, not now, we were worked a lot with high precision full arches, metal full arches. So you did the metal framework, try-in, it was perfect in the model, super. You applied ceramic, you finished the case, and it was not the same, right, Peter? What happened? The stresses, the shrinkage of ceramic in this soft metal, yellow metal, wants to bend it. So if you do the same stresses on zirconia, zirconia doesn't bend it. Zirconia, it will break. So you need to go very, very slow. And I never use one program. I use different program for one crown, different program for 5-unit breeds, different program for 6-unit breeds, zirconia or metal, and totally different program, very slow, about 1 hour and 30 minutes for full arches of zirconia. This is the minimum, 1 hour, 30 minutes, the whole procedure, very slow.
Thank you.
Okay, one last question. I think this is could be for all of you or any of you. In a real-world laboratory, could you put a percentage of cases where you would put all this art versus straightforward milled cases with surface stain and texture characterization?
Say that again?
In a real-world laboratory, could you put a percentage of cases where you would put all this art versus straightforward milled cases with surface stain and texture characterization?
I'm not sure really what they mean, but I could tell you from I think all of us might have a similar answer, but I'll tell you my perspective first. I've been honored that I get to travel around the world and work in all different types of laboratories over the years. And the ones that I find are struggling the most are the ones that are just kind of mill, stain, and glaze to get things out the door price-wise. The ones that are applying the artistry and the technology and utilizing materials usually can't seem to keep up with the volume of work that comes to them. So if that's what their question was, I would say that you're either a laboratory that does one or the other. It's very difficult to do both. That doesn't mean that I don't do monolithic crowns. Of course I do, but I choose them for the right scenario rather than just being this is faster and cheaper or more productive.
Yeah, I can also say something to that, and I agree with Peter. And I think we all, if we do just stain and glaze in a production setting or in a more setting where we do more complex cases, all the art and love into these cases, I think right now in these times where we are right now, pandemic times, we see the difference. And when I see friends, they have laboratories, they're more steered towards a single crown monolithic stain and glaze, they're out of work in 2 days because these cases are coming in and out and in and out and in and out. It's a very quick turnaround. When I now see us 4 here, I think we all still have work in the lab. Maybe not for the whole team, but we're all basically can work every day on cases they're just basically standing around because they're not done in 2 days. They are done in 2, 3, 4 weeks. Just they're so complex. And I think the future of our profession, if we would like to still be in business, is definitely more towards the, I don't like the word high-end cases, but more of the complex cases, more of the artsy cases, and to deliver not just a beautiful result, no, deliver the whole package, the whole service around that, the whole emotional package deal. What counts?
Which I think was kind of the point of today, Alex, right? I wanted us to kind of show a whole rather than just a spot of what the profession is.
It comes back to the topic of today's meeting. It's coming together, and it's coming together with 4 speakers here, coming together with all you guys, and all of you attended this meeting basically, from all over the world, to coming together to actually learning out of that time we never experienced before all together, and now actually coming into maybe a conclusion. We have to get better again. Yeah. So
good plan, I think.
My take on that.
Yeah, my take on that also, just on that question, is I think we've worked for a long time to get to where we are at this point, and we're kind of, with our lab, it's just my wife and myself, so we're small, but we're also kind of in this niche market where over 99% of the cases that are in here are all implant telescopic cases. But I think in terms of what we put into it, I'll give my all. I mean, that's I think what we all strive to do is put all of our soul into these cases and do our best. That may not always come back to us with every client, because our clients a lot of times are at different levels. We might not get the photography back that we want, but I think we all put everything into it that we have, and I think that's been pretty evident.
Great.
Excellent. So Peter, I'll hand it back to you in a minute, but real quick, for those attendees seeking laboratory CE, the validation code for this last session is IDT 0417-4. Again, IDT 0417-4. I'll type that into the box in a minute. And again, the code that you've seen on at various times throughout the day today, the web or the URL cdeworld.com/validation-codes is where you go to do that. You click on that link, and then you go to that portal and print your certificate. So that'll conclude today's program. Want to thank everybody, all our speakers, all our attendees today. If you enjoyed this, we encourage you to go to cdeworld.com for information on next week's CDE World Live Master Series with Drs. Bob Margis, Stephen Chu, Rob Ritter, and Marcus Blatz. Also follow IDT on social media, Facebook, Twitter, LinkedIn, Instagram for information on future events like this. So thank you, everybody, and back to Peter to close it out.
Yeah, so Jason, thank you. And listen, I have to just let everybody know there's still almost 300 people here, and this was a brainstorm 2 weeks ago, and didn't get really approved to be able to do this until Friday afternoon last week. So everything that you see here was kind of put together in 1 week. And I'm usually the guy who mocks the social media because I'm not on it as much as the rest of you guys. But it was the social media and the email and the so forth that really got this all together. I think close to 800 people signed up all together. I'm sure some were here for half and half others, but in the end, what I really wanted to say was thank you. I could tell you I miss getting on a plane and showing up somewhere, and I can't wait to do it again. I'm looking forward to those days. I can't thank my friends enough, Arian, Alex, and Nandis for contributing and helping, and all the hours we spent yesterday and the day before organizing and talking. A lot of work goes into these events, and I can't thank you guys enough for being there for me. And I also really want to thank my Aegis team and the IDT team for all their support with the systems and working it through, and then jumping into Zoom and everything else we did. But most of all, I want to thank all of you who are with us today. I can't tell you how much it means to me that I can show up somewhere and see all your faces all the time, and that you can jump on and support us the way you did, the way we hopefully tried to support you today with a little bit of motivation and excitement and getting raring to go back. So thank you all. It means a lot to me, and I hope to see you all again soon.
Thank you.
Thank you, Peter. Thank you.
Take care, everybody. Thank you
Thank
for
you.
a great job. We're 5 o'clock on the nose.
Awesome.
Perfection.
That's all odds, right?
Thank you, guys. Love you all. Thanks so much for helping out. And
And thanks all the technicians, the technical there that it was behind and support us about the presentations. Thank you so much, Peter. Thank you for this activity and organization. Big honor for us. And stay healthy, all of you.
oh, everybody, healthy to everybody.
Stay healthy.
All right. Stay healthy. Thank you, Peter.
Take care, everybody.
Bye.
Bye, everybody.